Richard Green is my consultant colleague who works at what is an excellent rhinological unit in the UK, so at Dundee.
This was actually something that was set up a few years ago when I was still a senior trainee in Dundee, and I've kind of taken on the role as a new consultant. And I just want to say thanks very much to the BRSJ News for asking me to talk about this, because it is a bit of a pet project of mine, but also it's a very, very common exam topic for a number of reasons, but it's quite easy to get these patients in for the clinicals because they're normally got fairly good signs. And they're used to being examined, so it can come up in the viva and also in the clinical. So for you studying for the exams and registrars, it's important to know how to manage these patients, and it's something I think over the last kind of few decades, as we're getting more and more evidence, we're doing increasingly kind of better in terms of managing them, but I think there's a long way to go with that. So we're going to go through the topics you can see on the left-hand side, and I'm going to finish with a little bit of an exam summary of what you should probably know if you're aiming for a level 6 just to pass in the exam, and then if you're going for the 7s and 8s, just some more of the evidence and some more in-depth knowledge of the medical and the surgical management regarding HHT. So when we look at HHT, what is it? So it's an autosomal dominant disease, which affects, we think, 1 in 5,000 people, but we know a lot of the time there's a significant proportion of patients with HHT who don't seek medical care. And when it comes to the screening side of things, you'll see why it is important that we try and educate the population and educate patients and families, because obviously it's autosomal dominant, so it runs very strongly in families, as to why it's important to be seen, even if they don't have any symptoms, so that they can get the appropriate screening and management. So it's characterized by telangiectasia and AVMs, and the AVMs can be in the lungs, can be in the liver and the brain, and rarely in the pancreas and the spine. And there's 2 reasons why these telangiectasia and AVMs form. So there's a dilation of the capillary venule, and where you would normally have the vein following a nice capillary bed to take the pressure off the venous system. In HHT, you tend to have a defect in the capillary bed, so the arterial system is almost in direct contact with the vein, and so the larger AVMs are thought to arise really just from smaller lesions as they get progressively bigger. But there's also aberrant angiogenesis. So, and this is one of the reasons why you don't see often patients be very symptomatic in their early decades. So in children and in their 20s and 30s, a lot of the time patients don't have symptoms, and they tend to present later on in life. So, the kind of classic HHT patient is someone in their 50s and 60s who's just over the last kind of few years been getting repeated worsening epistaxis. And this is because some of the telangiectasia are caused by trauma. So as you kind of go on in your life, you get more repeated trauma in the nose and wounds that are opened up. You can get these new vessels growing, and the new vessels have got a bit of a defect in the wall, so they're quite thin-walled vessels. And so this just shows, it's a little diagram showing you'd normally have a nice capillary bed separating the artery and the vein, and in HHT you tend not to have that. And in the new vessels that grow, these walls are fairly thin. So it's not apparent at birth and it evolves with age, like we said, but the cerebral AVMs tend to be complete in childhood, and the pulmonary AVMs, and we'll come on to this a little bit in terms of when you would screen children, they can be hormonal, so they can tend to occur or get worse during puberty and also during pregnancy. So when we look at the genetics, there's a large variation in expression. So even if you've got a family and they've got, say 2 sisters have got exactly the same genetic variant, they can present in very different ways. One can have a pulmonary AVM, one might not. One can have significant epistaxis, the other might not. So just because they've got the same gene, they can often present with different symptoms. And males and females are affected equally. And there's 5 genes, and really for the exam, and if you're going to remember a couple of them, it's the main ones are the ENG, so the endocrine gene, and the ACVRL1, which is the ALK1 gene. So the ENG gene is more commonly associated with pulmonary and cerebral AVMs, and then the ALK1 gene is more common with hepatic AVMs. And then the last one, we'll talk a little bit later on about this, just in terms of screening and follow-up, you need to be aware of is the SMAD4 gene. And this is rare, but it does carry the issue of juvenile colonic polyps, and so therefore risk of colonic carcinoma associated with that. So how do patients present? So the reason why ENT, the reason why we see patients with this is because the vast majority of patients will develop epistaxis over the years. So 90% have epistaxis, and then cutaneous manifestations. So the you can see the classic ones around the lips and around the face of the small telangiectasia are very common. Pulmonary AVMs are much more common than you think. So in up to 50% of the population who've got HHT, and this is the big thing. One of the take-home messages from today is we need to treat the pulmonary AVMs to reduce the risk of these, when you can see how they present with significant hemoptysis, stroke, brain abscesses. So this is one thing that we should be screening for and managing appropriately. So GI telangiectasia, so they're very common, and occasionally they can bleed. So if you have someone who's got GI bleeding, or someone who not has much in terms of epistaxis, but they are iron deficient and anemic, you need to rule out a GI bleed, and also rule out, obviously these patients are in their 50s, 60s, however old they are, and you need to be able to rule out other potential causes of iron deficiency anemia, obviously the main one being a malignancy. So hepatic is fairly common but rarely symptomatic, and then cerebral, again, thankfully is fairly infrequent, and again a lot of the time is asymptomatic, and spinal is even rarer. So for the exam, in terms of your diagnosis, there's two things. You can diagnose it clinically, and then you diagnose it by referring to a geneticist who will do genetic testing. So the Curacao classification is the one that you need to know for the exam. And you can see on the right-hand side, these are the kind of classic telangiectasia on the middle turbinate and the septum there. And so this is a Curacao classification in the table. And 3 or more is a definitive diagnosis, 2 more is likely, and 1 or 0 is very unlikely. But if you've got a positive family history and a first-degree relative, so they're going to have a 50% chance of having it anyway. So if they've got that and epistaxis, that's pretty much diagnostic of HHT. So Curacao was an island in the Caribbean, and there was a Dutch settler that went there who had HHT. So they've got one of the highest populations of HHT cases in the world, and that's why a lot of research is done over there, which is why it's called the Curacao classification. So in terms of screening, you will, if you Google this or if you look at papers, there's a lot written about this because it's quite controversial. And I'll tell you kind of what is written in the literature, and then more practically what we do in the UK. So in 2009, there was a kind of a position paper on this, and it was international guideline, and they suggested screening everyone for every potential AVM. But realistically, we don't do that in the UK because, and I'll show you in the next few slides, with the cerebral and the hepatic AVMs, until kind of recently, there wasn't the treatment for that was fairly morbid, and so therefore we wouldn't screen unless patients were symptomatic. So in the UK, so there's a number of centres now. There's one in London, one in Liverpool and Leeds, and we've got one in Dundee. I'm sure there's probably 1 or 2 others, where you've got a kind of an MDT that'll make these decisions. So screening of the lungs is important, and everyone should have screening of the lungs, or be offered screening of the lungs. And then we only screen other parts of the body if they are symptomatic. And so that's why it's important that you know how they can present. So with headaches, with new onset epilepsy, you would screen the brain if they've got and we'll go into some of the hepatic presentations as to when you would screen the liver. And really, it's if they had an asymptomatic AVM in the brain or the liver, are we going to do anything about that? So big take-home message: screen everyone in terms of their lungs, and you can screen them either with a bubble echo or a CTPA. Now, a lot of the time, or sometimes there can be a bit of delay in getting echoes, and even if you get a bubble echo and it's positive, you'll go on to get a CTPA. So we tend to go for a CTPA as the first kind of screening tool, and then it's just a 1 investigation and you're done. And you can see on the in the image there quite a large pulmonary AVM here. So you screen the lungs because it can, a lot of the time they're asymptomatic, but they can have issues with dyspnea and increasing shortness of breath, and they can present with hemorrhage as a result of these. But one of the main reasons for screening and treating these is that there is an increased risk of stroke and also an increased risk of infective cerebral events. And this is several hundred times more than the general population. And so this is why, and there's a good treatment for pulmonary AVM, so this is why we need to screen them and then treat them. In terms of if they have really significant pulmonary AVMs, they can get pulmonary hypertension and right-sided heart failure as a result of that. So screen the lungs because there's a good treatment for it, which we'll come to in a minute. So why we don't routinely screen the brain is on this slide, and this is the Aruba trial that you can see in the top right. So we know about 10% of patients will have a cerebral AVM, but there's lots and lots of different types, and all the different types convey slightly different risk of hemorrhage. And there's a big variation around the world, and you'll see, as I say, in America and in other parts of Europe, they will screen everyone for this. But the management is either endovascular embolization or surgical resection, and there's significant morbidity associated with that, and unfortunately mortality. So the Aruba trial was in 2014, and that looked at a surgical intervention group or medical management group of these AVMs. Now, these weren't, because the number of patients with HHT is relatively small, this wasn't a trial looking at just patients with cerebral AVMs and HHT. It was generally just with cerebral AVMs of various causes. But the trial was stopped early because there was a threefold increase in adverse events in the intervention group. And those were of stroke and significant morbidity. So the VASCERN is our European Vascular Network group, and they have started, so they've got a number of publications that are really useful with regards to HHT. And so they've said patients should have the opportunity to discuss screening. So a lot of patients have got anxiety regarding screening, or they may have had someone who's had an adverse event from a cerebral AVM, and in that case you need to discuss that with them. And sometimes we will screen people, but it's after a discussion with ourselves and with a neurosurgeon, because if you screen someone and they've got an asymptomatic AVM, what are you going to do about it? So we will speak to a patient in the MDT, and if they want to go ahead with screening, we'll then arrange for them to discuss this with a neurosurgeon, and they can go into more detail prior to being screened. So then the liver, in terms of screening with the liver, so GI hemorrhage is seen in about kind of a third of patients, and we wouldn't routinely screen someone in terms of an endoscopy unless they were symptomatic. And with hepatic AVMs, again, they're relatively common, but thankfully they're not symptomatic very often. But if patients do present, they can present with fairly significant symptoms like high output cardiac failure, portal hypertension. So we would screen if someone was symptomatic with a Doppler ultrasound, LFTs, and then an echo because of the cardiac failure if they had a positive ultrasound. But in the this European guidance document, so again, they've said if asymptomatic, they wouldn't recommend any treatment, and therefore if you're not going to treat someone who's asymptomatic, why would we necessarily be screening for them? This may change, and I'll come to the management shortly in the future, because bevacizumab is now a potential treatment for patients with significant hepatic AVM. So this might be the thing that changes, because we might have a treatment that is actually relatively low risk that can help these patients. And anemia. So a lot of patients are anemic, either from bleeding from the nose or the GI tract, and they've also got an increased risk of stroke in this population. So you'd manage them as whatever your local guidance is regarding this. And then again, we'll come to the VASCERN guidance on the next slide, but you need to monitor that, and either yourself if you're running an MDT, or the GPs need to monitor with regular hemoglobin and ferritin levels. So this is a big document, and when we set up the MDT, this was probably the thing that we tried to get all of our patients through the MDT and give them these, give them either this advice or these investigations. So screening for pulmonary AVMs for every patient, written nosebleed advice, and a lot of the time these patients have had really poor experiences with either GPs or E&E departments managing their epistaxis, because, you know, it's understandable that, you know, when they seek advice from these healthcare professionals, they don't entirely know what's going on with regards to their disease. And so really giving them some advice on how to manage it in the house, but also what to do if they are really struggling, and give them contact numbers or ways to get in touch with an ENT department, rather than necessarily going through you know, healthcare professionals that don't know what to do with these patients. So then treating that, or monitoring the iron deficiency and treating that appropriately. If they've got pulmonary AVMs, or they're awaiting investigation for that, then they need to have written advice regarding antibiotic prophylaxis with regard to dental and surgical procedures, and this is to reduce the risk of those cerebral infections. And then again, we'll come on to pregnancy in a few slides time, but give patients who are either pregnant or thinking about having a family, give them advice regarding that, and also discuss that with the obstetricians. So what else can we do? And when we see patients in clinic, what we do, we've got a specialist nurse who does all of these for us before the clinic, which is great and really helps us out. But do a visual analog score and a quality of life questionnaire. So this is just a generic quality of life questionnaire, which is used throughout a number of studies and various other specialties as well, not just in ENT, but it gives you a general idea of how the patient is managing with their daily activities in their life. Because one of the big things before we set up the MDT, had a patient support group where we got all the patients, our kind of regular attenders, together and discuss with them what they would want out of an MDT and out of the service, and also how HHT impacts them. And it was really, you know, kind of amazing. And you think we just get used to dealing with them with regards to the epistaxis, but so many of these patients couldn't work, or had lost jobs, or you know, they socially were very isolated. They didn't want to go out to eat in restaurants. They were embarrassed about, you know, bleeding there. They didn't go on holiday because they didn't know how to manage their epistaxis when they were going potentially abroad. So it can have a huge impact on their quality of life. And so I think it's really important, especially if we're going to start to give them some more novel treatments, is to be able to monitor how they are able to hopefully get back to an improved quality of life. And then the ESS is your epistaxis severity score, and this is used now a lot of the time in just in epistaxis in general, but was really designed regarding the monitoring of HHT patients. So this slide shows you, so this is a really good organization, Cure HHT, so it's an American organization. And we get patients to fill this in online beforehand, so they can give us their epistaxis severity score. They just go to this website, and it's got this calculation there. And you can see there's 6 questions, and it's within the last 3 months. They answer these 6 questions, and it gives them a score from 0 to 10, 10 being horrendous, 0 being no issues. And so it really, again, helps us monitor how patients are doing when we are, you know, changing treatments. And also when we start to think about potentially giving monoclonal treatments with a bevacizumab, there's got to be some inclusion criteria for that, and an epistaxis severity score is one of those in the inclusion criteria. So with regards to managing the epistaxis, so when we're thinking from an ENT surgeon point of view, there's a few areas, and one of the areas is the emergency. How do you deal with an emergency when someone's having a fairly significant epistaxis? And what you'll tend to find is actually patients will present relatively late, because like I said, they've often had poor experiences, and they're used to managing these nosebleeds at home. So by the time they get to you, they could have been bleeding for a really you know, extended period of time. So standard first aid advice: avoid packing if possible. And that's again because when we were looking at, you know, the cause of these new vessel growths, a lot of the time it's from trauma. So if you go and put your standard rapid rhino in and inflate it and cause a significant amount of trauma, that's likely to actually then induce a lot of new vessel growth. So try and avoid packing if you can. So think about other adjuncts you can use, like Flow Seal and Surgicel, and also try and either correct if they're hypertensive, look at that medical side of that management, and also tranexamic acid. Pack with the low pressure pack if needed. And bottom line though is, if they're struggling and they're still bleeding heavily, you're going to need to pack them as you would and treat them, you know, as other epistaxis. So you know, you might need to do with a rapid rhino or a BIP and Foley and resuscitate them, And then occasionally you may need to go to theatre. And if you're going to go to theatre, try and use coblation or KTP laser if you've got it. If not, then bipolar, and use suction monopolar kind of last, because it can cause a little bit more trauma and then therefore kind of increase the new vessel growth. There's been some studies looking at embolization, and so if you're really struggling surgically and you've just got the nose packed and you can't get on top of this, then you can embolize. But you know, there's small numbers in those studies, but that is one option for you. So from an ENT, from a surgical point of view, and again for the exam, so a lot of the, you know, the first few kind of slides here are talking through some of the theory and questions that you might be asked regarding screening and whatnot, but this is your bread and butter, how you're going to deal with them, the epistaxis. So you're going to have the medical management and then the surgical management, and both of those you're going to treat in a nice kind of step ladder approach. So in your first line, everyone should get epistaxis advice, you know, as per the European guidelines and emollients. And then second line are going to be these medications. Now, these are all off license with relatively poor evidence based, and as I've been finding out recently, are quite difficult to get through your hospital pharmacy onto your regular kind of prescribing guide. But they are all useful in their own way. And from my point of view, we often use tamoxifen and tranexamic acid as first line, and we go to propranolol or thalidomide if they can't tolerate these. So tamoxifen is an estrogen receptor modulator, and it's got anti-angiogenic properties. When you've got to be careful is if patients are, you know, you can't give it if patients are pregnant or thinking about that. So in younger women, we tend to not give tamoxifen. I'd normally start with propranolol. If they've had a recent DVT or PE or uterine cancer. So they all get a patient information leaflet on these because they're off license regarding the side effects. So if they get any unexpected vaginal bleeding, they need to speak to their GP and get investigated for that. Tranexamic acid, so it's very common now in standard epistaxis management, and we give it fairly regularly now, and we've had some really good results with this. You tend to give it just twice a day rather than 3 times a day. And again, you've just got to be open with patients that it's off license, but it's fairly low risk. You've got to be careful if they're on the contraceptive pill or if they've had some thromboembolic event. Propranolol works similarly to we think with your subglottic hemangiomas, so causes some vasoconstriction, reduction in blood flow, and affects the vascular endothelial growth factor. And you've got to be careful with cardiac disease and asthma. And then thalidomide, I'm sure as you all know, you'll be very careful again in younger women who may be thinking of being trying for a family or becoming pregnant. And then third line, and this is one of the big things, again, if you're going for your 7s and your 8s and an exam, there's a big study on the next slide, and bevacizumab is kind of going to be what a lot of the HHT centres will be given as their third line treatment when all medical and then surgical treatments have failed. So I'll come on to surgical treatment shortly. So you wouldn't just go down the medical route. You'd often give the first few lines and then go to your surgical route and then come back to the bevacizumab if everything else has failed. So what is it? So most of you will have come across it. It's got a number of different uses. It's a monoclonal antibody that inhibits VEGF, and initially there was lots of different applications for it. So you could give it topically, either by an injection, or you could just put it on topical kind of patties, and they didn't work. There was some improvement in the submucosal injections, but now the INHIBIT study, which came out last year, which is the largest study that we've got in HHT treatment, really was 12 of these centers of excellence came out and were given this for patients who had really significant epistaxis or GI bleeding, and there were really good results. So they had an increase in hemoglobin of 3 grams, decrease in that epistaxis severity score of over 3, and a significant decrease in the need for the iron and blood transfusions, and thankfully there was very few adverse events and no fatal events. And you know, PE was thrombolic event was seen in 2%. So this is a lot less than, because it can be given in bowel cancer, and the rate of thromboembolic event was a lot less than in the bowel cancer. You know, probably because of the nature of having a tumor will give you more likely to have a thromboembolic event anyway. So this is the new thing that is going to be a game changer really for the patients where you're really struggling with. So your surgical management, what have we got? Well, you're going to start with your thermal treatments, and then you've got some other surgical treatments if you're really struggling. And going forward, given what we've seen in the previous slide, we'll wait and see how many or how this is affected by that and when that becomes more available. But your thermal treatments, you're going to try and avoid suction monopole if you can, just because it causes a lot more thermal damage, and that's likely to lead to more vessel growth. So laser, KTP laser, and in the exam, if you mention a laser, a certain type of laser, you need to know about that. So KTP, the wavelength's a lot less than with your CO2, so it's absorbed by hemoglobin. And so ideally, you can see the KTP laser in the top right. And so you have it about 1 centimeter or so away from the lesion, and then you're going to fire the laser. And what should happen ideally is that the hemoglobin underneath will coagulate, but you'll keep the mucosa intact over the top. So you're not causing the trauma to the mucosa, so you shouldn't get new vessel growth around it. And that's the kind of ideal treatment. So septodermoplasty, you're going to take off a big part of the septum and then graft a split thickness skin graft onto that, which is really good for, you can cover a big area of the septum. If there's loads and loads of these small telangiectasia, it's very good. But you can get a lot of symptoms then in the nose with crust, and you can get new vessel growth coming through or around the split skin graft. And then a Young's procedure where you're going to close the nostril. You can see in the bottom right that the kind of the diagram there. So Valerie Lund has shown a really good case series of about 100 patients where she got complete cessation in the epistaxis of about 94%. And this was actually really well tolerated. And again, it goes back to how symptomatic these patients are. So they can't work, they're socially isolated. So this is, if you close off your average person's nose, they're going to be really symptomatic and not really tolerate that very well. But in these patients, they would do anything to really stop these nosebleeds. So Young's procedure in the right patients is really well tolerated. So management of the other visceral AVMs. So like we said, the lung AVMs are relatively easily treated with our interventional radiologist. And it's a low risk procedure and a really good outcomes with those. So we treat those. They need antibiotic prophylaxis until the pulmonary AVMs are treated. With the GI and your liver, so if they're having a GI bleed, you'd manage them and refer to them as you would with any other GI bleed in your hospital. And like we said, the potential for colorectal malignancies is not to be missed. And with the hepatic AVMs, if they were symptomatic previously, then really the only treatment you had was a liver resection and liver transplant. But now with the bevacizumab, again, high upper cardiac failure patients who were on a liver transplant list were treated with this and actually reversed some of the need for liver transplant. So going forward, and again, this comes back to, we'll probably screen more of these patients because we're going to have a better treatment option for them. So last few slides, other important points. So with a SMAD4 mutation, like we said, you need to think of treat them exactly the same up until you're going to have something else that you're going to need to think of with regards to the MDT. So these patients need to go on a regular screening for bowel cancer register. So we've got one of our GI specialists who we would refer these patients to, and every year they get a endoscopy and a colonoscopy. And that is, unfortunately, we have a few families in our area who've got this, and we've had a young patient who died as a result of colorectal cancer. So that's what you need to remember with a SMAD4 mutation. In children, there's a lot of controversy around screening again, and again, if you read the literature in North America and in the rest of Europe, they're very keen on screening everyone. So we tend to be a little bit more conservative. And Claire Shuvlin she's a professor in London, and she's, I guess, just the guru on all this. She's written a lot of the references that I've put in the talk today. She's written the papers on, and so I kind of guided. I tend to do what she does with a lot of these things, and she would, in asymptomatic children, she would just screen them at around the pubertal age, because that's when potentially these pulmonary AVMs can grow and become more symptomatic. So she'll do a pulse ox screening on children, and she won't screen the rest of them in terms of the brain and liver unless they are symptomatic. Other points of pregnancy. So luckily, the vast majority of the time, patients with HHT will go on to have a successful pregnancy without any complications, but there is a fairly significant risk of life-threatening complications and unfortunately maternal mortality. So you can't ignore this. Patients need to be aware of this when either they are pregnant or when they're considering pregnancy, and that's again when a lot of the MDT education side of things comes in. And there's been some recommendations to try and screen and treat pulmonary AVMs prior to conception. If you find one in an asymptomatic patient, don't treat them during pregnancy. But patients just need to be aware if they develop hemoptysis or sudden dyspnea that they need to come into hospital straight away, so they can have, when we talk about the major life-threatening complications, major pulmonary hemorrhage or a stroke, they're the main ones. Antibiotic prophylaxis, again, like we've talked about with pulmonary AVMs, try and avoid prolonged stages of labor in patients who you haven't screened the head for in women who are pregnant. So getting back to, so the MDT, what do we do? Well, the vast majority of our role, I think, is education, both for the patient, but also for GPs and other people who might be looking after the patients. So having good documentation in the notes and online so that people can manage these patients properly. So really talking through patients, what the disease is and how they're going to manage it. In terms of teamwork and support, so in a lot of the slides, I've talked about pulmonary AVMs or the AVMs. So these are not things that I would manage, but working in the MDT, you need to know who to refer to. So one of the things when we set up the MDT was going to speak to all of these different subspecialties and try and have a lead in that, in that area. So we've got a respiratory contact, we've got a hematology contact regarding, if patients are really iron deficient and we're struggling just with routine things, how to manage that. So you need to have contacts in all of these different subspecialties so that you can help these patients with these issues. So if you get someone into a clinic as a ENT surgeon and you think they might have HHT, what are you going to do? Ask about systemic symptoms, refer to a geneticist for testing, start on your initial nasal management, take some bloods, and then perform an epistaxis severity score. So that's what you would do and refer. If you confirm the diagnosis, then give them information and support, and then do that. Follow those European guidelines in terms of investigations and management, and screen if you've got any other symptomatic features from these other visceral AVMs. And then for the exam, and this is it's a very quick summary. Before the exam, you need a good definition in your arsenal. So if they say, what is HHT? You need to be able to come out with something that makes sense, that covers the first kind of what it is and how it presents. Know something about the diagnosis, so clinically and then genetically, and referring to a specialist clinic. Investigations, be able to say something about what you're going to investigate and why you might not investigate the other organs. And then management, get some papers in there, the VASCERN paper, the inhibit paper, and say that's how you're going to management, and go down your step ladder of your medical and then your surgical management. And if you're going to learn 2 papers, that VASCERN kind of position paper on how we should be screening and managing patients, and then the big inhibit bevacizumab paper would be the 2 that I would recommend. So they are all the references, and I'll take any questions. Yeah.
So is there a role for silver nitrate cautery in the management of HHT epistaxis?
So I'll be very careful with silver nitrate cautery. So if you say you've got a patient in clinic who's got a nice telangiectasia there, I would leave it well alone. Especially, so we sometimes see patients in a follow-up clinic and you barely look in the nose because you know what you're going to see. And even just putting the scope in, if you knock one of these telangiectasia significantly, you're going to have a really bad epistaxis on your hands in the middle of clinic.
Get angry, do you?
Yeah, exactly. And everyone is then not very pleased with you. In terms of the acute management, say the patient was coming in and they were bleeding anyway, and they were in the middle of the night. You've got no harm in trying a bit of silver nitrate cautery. I've got to be honest, it would rarely work though. So some of those, a little bit of topical adrenaline on some cotton wool and then a bit of flow seal or a bit of Surgicel or something else like that is more likely to work than the silver nitrate. But you wouldn't, if they're already bleeding, you wouldn't have anything to lose by kind of trying that.
Yeah, and I think I'd add to that is that you don't want to use anything. You mentioned coblation and KTP laser. You don't really want to use anything that's going to stick to the mucosa, or that you
Yeah.
want to sort of physically make a contact with the telangiectatic vessel. So anything that you use to thermocoagulate needs to be at a distance, right, Richard? Fair enough?
Yeah. Yeah, you want to try and leave the mucosa alone as much as you can. The more trauma you cause, it's difficult in the short term. Yeah, you might be able to get on top of that, but you're more likely to cause new vessel growth kind of around that.
So, Richard, then in a patient with a negative CT pulmonary angiogram, do you repeat it at an interval? And if they become pregnant later on, would that require repeating?
Yeah. So if they become pregnant after the pregnancy, you could, because you can develop them during pregnancy. So you could repeat that afterwards. But once they've had a negative one, especially if they're the ALK1 mutation, I would never normally rescan them. If they are an ENG mutation, and if they've got any symptoms, I'd scan them again, because they can develop them.
Which I'm going to try to interpret this next question, but it's a bit it's confused me. So I'll read it to you. So it's often asked by medics to preemptively cauterize patients with a diagnosis of HHT when they're thinking about starting anticoagulation. This is declined locally to whoever's asked this question. I'm not sure what they're asking for evidence for. The evidence for the cauterization or the anticoagulation, but
I'd just leave them well alone unless they're bleeding. In terms of, I wouldn't go cauterizing ones that don't need to be cauterized. We've got a few patients who are on warfarin, actually, who've had strokes and all sorts, because there is that risk of stroke with these patients. And so we do have some patients that are anticoagulated. But yeah, I wouldn't do anything unless they are actively bleeding from them or having issues.
Yeah, Richard, and also thank you for that. And these are palliative patients, right? We're not going to cure them. Okay, so it is best quality of life that you can provide for these individuals. Yeah.
Yeah, and I think anecdotally, so since we've started the MDT, I think a lot of the medical management, so we're operating a lot less on these patients, because they are off license. There are side effects of these medical managements, but they a lot of the time they work, and you can get someone fairly kind of not symptom free, but just controlled, and compared to what they're like, it can be a real nightmare for them. So if you can just improve it by 50%, they're often really kind of grateful and happy with that. So yeah, a lot of the time, you're not going to cure them, but you can just get them to the point where they can function.
And are you starting to see that when you follow these patients, that their disease naturally fluctuates? So they might seek your attention when they're having a particularly bad time. By the time you get to see them, by the time you get them on an operating list, they've actually improved. Is that what you tend to see, this sort of fluctuation?
Yeah, we do. And actually so sometimes we give patients like kind of rescue packs, if you will. So we've had some patients where they can kind of give themselves a short course of tranexamic acid, for instance. So if they're going on holiday or they're having a bad spell, they can just go and get a week's course of tranexamic acid from their GP, because it will kind of wax and wane quite a lot. Yeah, we do see.
I've done that with Flow Seal. I've shown patients how to mix it up. I've done it with Rapid Rhinos. These are sensible people who understand their disease process. And just finally, your outcome measures. So you mentioned it briefly there, reducing someone's epistaxis by 50% can improve their quality of life.
Yeah.
What are your sort of outcome measures for when someone's doing okay or when they need an intervention?
So the epistaxis severity score is really good. So if that's coming down by 1 or 2, that normally correlates with them feeling significant improvement in their quality of life. And then their ferritin levels and their hemoglobin levels. So if they're needing regular transfusion and regular iron transfusion, so we start a lot of patients on just oral iron, but if they're starting to get to the point where they need IV iron, and then you think, we're not winning here, we need to go down that ladder approach and try something else, or bring them in and to have a surgical management.
Yeah, so blood transfusions and admissions to hospital.
Yeah, and when you look at the trials that looked at the bevacizumab in terms of their criteria, it was an epistaxis severity score of about 7. Blood transfusions, iron transfusions, failed all these other things, and that's what we use for our criteria for that. So yeah, they're the main ones.